This podcast is hosted by Will Glomsky. Will is an experienced critical care paramedic working on a ground ambulance. This podcast is purely educational, and the opinions reflected are of the hosts only. This show is not intended to supersede any local protocol or training. This podcast covers educational content surrounding emergency medical services. Welcome to the Midnight Medic Podcast.
Hello and welcome to another episode of the Midnight Medic Podcast, the podcast that explores the ins and outs of emergency medical services. I'm your host, Will, and today we're going to focus on a common but critical respiratory emergency, asthma. Asthma is something most of us are familiar with, whether it's through personal experience, a family member, or somebody in the community. But for EMS providers, treating asthma exacerbations in the field can be a challenge. Asthma is a condition that affects the airway and can cause wheezing, breathlessness, and coughing. In severe cases, it can lead to respiratory failure if not managed correctly. In today's episode, we'll break down the basics of asthma, the signs and symptoms you need to be aware of, and most importantly, the pre-hospital treatment strategies that can help manage an asthma attack and stabilize a patient. Let's start by quickly reviewing what asthma is. Asthma is a chronic condition where the airways become inflamed, swollen, and produce extra mucus, which makes it difficult to breathe. The airway obstruction can be triggered by a variety of factors, including allergens, exercise, cold air, respiratory infections, and even stress. An asthma exacerbation or attack occurs when these symptoms worsen, leading to significant difficulty breathing, wheezing, and tightness in the chest. It's important to recognize that asthma attacks can vary in severity, ranging from mild wheezing to life-threatening respiratory distress. As an EMS provider, you'll often encounter patients that may already have a known history of asthma, or those who are experiencing their first asthma attack. It's essential to assess their systems quickly and determine the severity of the attack in order to guide your treatment. Now let's talk about the signs and symptoms you'll see in the field. The hallmark signs of an asthma attack include wheezing. The high-pitched sound when exhaling is due to narrowed airways. Shortness of breath. The patient may appear anxious or struggling to catch their breath. Chest tightness. The patient may report a feeling of pressure or constriction in the chest. And coughing, especially at night or early morning. Persistent coughing can be a sign of poorly controlled asthma. In a severe asthma attack or exacerbation, the patient may exhibit a silent chest. This is a dangerous sign where there's no wheezing because the airflow is so severely restricted that little air is moving through the lungs. This is a true emergency. Use of accessory muscles. You'll see the patient working hard to breathe, using neck, chest, abdominal, those intercostal muscles, belly breathing. Tripoding is very common with this to try to increase PEEP. Cyanosis is another very common one, a bluish tint to the lips, face, or extremities, which indicates a lack of oxygen in the blood. And altered mental status. This could be a sign of hypoxia or low oxygen levels affecting brain function. When you arrive at scene, your primary goal is to determine how severe the asthma attack is, assess the patient's oxygenation status, and start appropriate treatment as soon as possible. So how do we treat asthma exacerbations in the field? Well, the mainstay of asthma treatment is focused on bronchodilation, opening up the airways and reducing inflammation. Let's go over the key treatment steps, starting with oxygen. If the patient is in respiratory distress, oxygen should be administered right away. Oxygen saturation levels should be monitored closely, and if it's below 94%, or if the patient is showing signs of significant distress or cyanosis, supplemental oxygen should be administered via a nasal cannula or non-rebreather mask. The goal is to maintain oxygen saturation in the 94 to 98% range. 94 or above is considered good. Albuterol is a beta-2 adrenergic agonist, meaning it stimulates beta-2 receptors in the smooth muscles of the airways. When these receptors are activated, they'll cause the muscles around the airways to relax, leading to bronchodilation, the widening of the bronchial tubes. This helps improve airflow and alleviate symptoms like wheezing, coughing, and shortness of breath. Albuterol is a short-acting medication, meaning it works quickly to relieve symptoms, but has a short duration of action, typically lasting 4 to 6 hours. Common uses are asthma attacks. Albuterol is commonly used as a rescue inhaler for quick relief of asthma symptoms during an acute exacerbation, such as shortness of breath or wheezing. A lot of patients who have asthma are going to have a rescue inhaler or a metered dose inhaler that contains albuterol. COPD flare-ups. Patients with COPD use albuterol to manage acute flare-ups of difficulty breathing or increased mucus production. Exercise-induced bronchoconstriction or exercise-induced asthma, sometimes used to prevent bronchospasm triggered by physical activity in patients with asthma. I used to play lacrosse, and I have asthma, and I used to take a meter dose inhaler or a rescue inhaler. I used to take a couple puffs before I went out in the field to help open up my lungs and prevent that bronchoconstriction. Or other respiratory conditions. Albuterol is used in the management of other conditions that cause bronchoconstriction, such as bronchitis and emphysema. Albuterol comes in a few forms. It comes in a metered dose inhaler. This is the most common form for home use that our patients will have. This device delivers a measured dose of albuterol in an aerosolized form that the patient inhales. This can be used with or without a spacer. A nebulized solution, which is our most common choice here. In EMS, albuterol is often used. Albuterol comes as a nebulized solution, which is the EMS's most popular choice. It's often administered using a nebulizer, which turns the medication into a fine mist that can be inhaled directly into the lungs. This is especially useful in acute settings or for patients who may not be able to use an inhaler effectively. Albuterol also comes in oral tablets and syrups. This is less common in the acute management of asthma or COPD, but it is out there. The typical dosing for an inhaler is 2 puffs every 4 to 6 hours as needed. And for exercise-induced bronchoconstriction, it is used about 15 minutes before physical activity. In our world, using the nebulizer, we use 2.5 milligrams of albuterol in 3 milliliters of saline, which usually comes pre-packaged. It's nebulized for about 5 to 15 minutes at 6 liters per minute through a nebulizer, and often repeated every 20 minutes for doses. It's nebulized over 5 to 15 minutes through that nebulizer at 6 liters per minute, and often repeated every 20 minutes up to 3 doses in acute situations. Side effects of albuterol include tachycardia or rapid heart rate, tremors, nervousness or anxiety, headache, dizziness, muscle cramps, dry mouth, or throat irritation. In rare cases, excessive use of albuterol can lead to overuse of the medication, which causes heart problems, worsening symptoms, or reduced effectiveness. Some contraindications and precautions to consider: patients who are allergic or have a hypersensitivity to albuterol or other beta agonists should avoid its use. Patients who have cardiac issues, since albuterol can increase heart rate and cause palpitations, it should be used in caution with patients who have heart conditions, including arrhythmias or high blood pressure. Overuse or using the albuterol more frequently than it's prescribed can lead to rebound bronchospasm, where airways constrict again right after the medication wears off. And caution with some other medications. Albuterol has a few interactions, which include beta blockers, diuretics, or MAOIs. In the pre-hospital setting, albuterol is often administered by nebulizer for patients who are experiencing severe asthma or acute bronchospasms. This is considered our first-line treatment. For severe asthma attacks, it may be given in combination with ipratropium bromide, which we'll talk about next, or a duoneb for a synergistic effect to help open the airways. Key points to remember: albuterol is a rescue medication, not a long-term solution. It's meant to relieve acute symptoms but doesn't address the underlying inflammation. In acute respiratory distress, albuterol should be administered as soon as possible to alleviate bronchospasm and improve breathing. Albuterol is effective in both pediatric and adult populations, but dosages may vary based on age, weight, or severity of symptoms. And follow up with preventative treatment. Patients using albuterol frequently may need long-term medications, such as inhaled corticosteroids or long-acting beta agonists to control chronic symptoms and reduce exacerbations. Our next drug is ipratropium bromide. In more severe cases, or if the patient isn't responding well to albuterol alone, you may administer a drug called ipratropium bromide, which is another bronchodilator. Ipratropium bromide is a bronchodilator medication that is used to treat respiratory conditions such as asthma, COPD, and other conditions that cause airway constriction. It works by relaxing the muscles around the airways, which in turn helps open the airways and makes it easier for air to flow in and out of the lungs. Ipratropium is classified as an anticholinergic drug, which means it works by blocking certain receptors in the body that cause the airways to contract. Ipratropium acts by blocking muscarinic receptors in the smooth muscles of the airways. These receptors are involved in bronchoconstriction, narrowing of the airways, and by blocking them, ipratropium helps relax the muscles, thus dilating the airway and improving airflow. Ipratropium also is an anti-muscarinic agent. It helps dry out some of the secretions that are produced with conditions like COPD and asthma. It's commonly used as an adjunct therapy for patients experiencing acute asthma exacerbations when albuterol alone is not sufficient to relieve symptoms. Ipratropium comes in a nebulized solution, which is our most common. It's often delivered via nebulizer as part of a treatment for severe respiratory distress. When combined with a bronchodilator like albuterol, it's usually given in what is called a duoneb to improve patient outcomes. You also will see this in the field as a metered dose inhaler that patients sometimes take for asthma and COPD. Ipratropium is usually given in that combination with albuterol in a nebulizer. Standard dosing includes 0.5 milligrams in a 2.5 milliliter solution, administered every 20 minutes up to 3 doses if needed. For patients not responding to albuterol alone, further doses of ipratropium may be administered. Though ipratropium is well tolerated, it can have side effects, especially when used in higher doses or over prolonged periods. Common side effects include dry mouth or throat irritation due to that anticholinergic effect, coughing, headache, nausea, blurred vision if it accidentally gets in the eyes, tachycardia, and urinary retention, which is rare, mostly in patients with prostate problems. Ipratropium is not a first-line therapy, but a helpful adjunct when used in combination with other bronchodilators like albuterol. It's particularly useful in severe respiratory distress when immediate relief is needed and the patient isn't tolerating the albuterol alone. It is not a rescue drug on its own, but it can extend the effect of albuterol, making a powerful combination therapy in acute exacerbations of asthma or COPD. Our next treatment is steroids or systemic corticosteroids. If the patient's condition is more severe or you anticipate prolonged transport, you may need to administer oral steroids or IV or IM steroids to have them prepared for hospital care. Steroids help reduce airway inflammation and improve long-term control of asthma exacerbations. While EMS typically doesn't administer oral steroids directly, some systems may allow you to administer dexamethasone or methylprednisolone, IV or IM, for severe attacks. Our next tool in the toolbox is CPAP, or continuous positive airway pressure. In cases of severe respiratory distress where the patient is struggling to breathe but not in full respiratory failure, CPAP might be a useful option. CPAP helps keep airways open by delivering a constant stream of air pressure, preventing the airways from collapsing and improving oxygenation. This is usually given by a mask over the patient's face that is tightly fit. It is somewhat uncomfortable when the patient is first on it. We start out at a PEEP of 5 and work our way up to a PEEP of 10 as needed by adjusting the oxygen flow. The flow rates should be listed somewhere on the packaging for the CPAP. It's very brand specific. That PEEP helps keep air in the lungs at the end of exhalation to help keep the alveoli open and recruited. Other causes of respiratory distress can sometimes be complicated by factors like pneumonia or pulmonary embolism, which may cause similar symptoms but requires different treatments. If the patient doesn't respond to standard asthma therapy, consider whether there might be another cause for their respiratory distress. Once treatment is underway, continue to monitor the patient closely. Make sure to reassess their breathing, pulse, oxygen saturation, and mental status regularly. If the patient is improving, continue with the treatments and prepare for transport to the hospital if necessary. If there's no improvement, or if the patient's condition worsens, it's time to escalate care. And of course, communication with the receiving facility is key. When you're en route to the hospital, make sure to give them a heads up on the patient's condition and treatments. If the patient is intubated or you've administered multiple rounds of medications, this information is crucial for the receiving team to continue care without delay. 2 important questions to ask your asthma patients, especially if they're doing that 2 to 3 word sentences, are: do they have asthma? Has this happened before? And have they been intubated before? It's going to start to tell you how quickly you need to treat them. In summary, asthma treatment in EMS revolves around quick recognition of symptoms, immediate oxygen therapy, and the use of bronchodilators like albuterol and possibly combined with ipratropium. Don't forget to assess the severity of the asthma exacerbation and provide supportive care such as CPAP or corticosteroids as necessary. With timely and appropriate treatment, most patients will improve and be able to continue their care at the hospital. Asthma might seem like a relatively common condition, but in the field it can be life-threatening. By staying sharp, following protocols, and knowing your treatment options, you can help ensure the best possible outcome for your patient. Thank you for tuning in to this episode of the Midnight Medic podcast. I hope these tips help you out with your treatments. I hope to do more mini-series on different conditions within EMS that are very common or not so common, along with their treatments and medications given. If this was positive and helped you, give me some feedback. Otherwise, share with your friends, like the podcast, and I'll see you in the next episode.